So hi guys. It's Al Heuer. I'm going to be presenting to you on models of RT or respiratory therapy preceptor training, and I would say education as well. Some models are better than the others. It's a topic that's near and dear to my heart for the following reasons. You know, I 30 something years ago when I became a clinical instructor, which is not the same as a preceptor, and I'll make that distinction momentarily. Nobody sat there and showed me how to be a clinical instructor. And there's a lot of commonality between that and being a preceptor. It's something I kind of learned on the job. Did I do a better job 15 years after being a clinical instructor than my first year? Yes, there's no question about it. And I'm also, as I'm a little bit older and wiser, at this point in my career and in my life, I look at I look at how important it is to be a preceptor or an instructor or an educator. And I'm not implying that none of you are. Okay. When I did home care, I did a lot of education. When you work in subacute care, you do a lot of education. Even in acute care, you may do some as well. So I don't mean to imply that none of you, are in any way involved with education, but you probably have an appreciation for how challenging it can be. It's a privilege. It's a wonderful thing. I enjoy teaching. I enjoy precepting. I enjoy being a clinical instructor, et cetera. But it's an important role because we're preparing healthcare professionals in probably all of our cases, respiratory therapy students, or let's say new grads, to excel in the profession and to keep our patients safe and to have the best reasonable outcome that they can and contribute to that. Okay. So it's really, you're a fiduciary. You're in a position of very, very high trust. So it shouldn't be done mamby-pamby. It shouldn't be done by the seat of your pants. And again, I just admitted to you early in my career, it was kind of I was told a few, basic fundamentals, etc. I was initially, I had, the director of clinical did do, a partial day with me in the clinical site. So it wasn't like I was totally thrown to the wolves, but you get the idea. It was kind of, a bit of flying by the seat of your pants and learning as you go type of deal. This lecture is really aimed at maybe that's not the best model and discussing some of the model and resources that are out there. So let me get started with the actual presentation. The nitty gritty, if you will. So some of the learning objectives will describe the importance of preceptorship training for our RT students and our new hires. So you think about it. So it's preceptorship training, but they're the ones that are training the newbies, whether they be students or new hires or individuals maybe that have come from other sites and other settings. Important responsibility. Review the evolution of respiratory therapy preceptorship training. Not every facet of it, but some key milestones. Examine barriers to preceptorship training. Compare and contrast some of the strategies and models that are actually out there, including those to overcome some of those barriers. Review some of the resources which exist out there. So this presentation is also, it's going to sound a little strange. It's not just meant to share with you what I know, but it's also intended to share with you resources that are out there that you don't have to know everything. There's resources, really high quality resources from the AARC and beyond that are out there that can really, if you will, empower not just the organization doing the preceptorship training, but the individual who's desiring to be a preceptor. So to be clear, we're talking about a preceptor. And again, there's a lot of parallelism. The preceptor is, generally speaking, an employee of the hospital who is charged with precepting, charged with ensuring or helping ensure that the new grad, the new hire, the students who's rotating through gets the best educational experience that they can. Now, it may actually even be a somewhat experienced respiratory therapist who's, let's say, been doing home care for 10 years, and now they're going into acute care. So they don't need the same things that a new grad or a respiratory student needs, okay? But they still need to know what the code is, where stuff is, and it may have been quite a while since they've basically liberated patients from mechanical ventilation via, daily weaning protocol, implementation, things along those lines. Assisting with an intubation, a lot of blood gases and things along those lines. So the preceptor is, again, not generally the paid instructor from the educational program. Generally speaking, they're affiliated with the site or the organization where they're actually doing it. In many cases, and in our case, to be honest with you, even though I teach at several institutions, I still today I was doing clinical instruction, so it's not precepting, but I do clinical instructing at a tertiary at a critical care hospital, tertiary care critical care hospital, about 1,000 beds, big old hospital. But we also employ preceptors. So as weird as it sounds, there's times when I'm on the clock there. I'm working for the hospital system where I'm a preceptor. No, I'm not doing preceptorship and clinical instruction at the same time, but you get the general idea. So why do we care about preceptorship training? In some of my other lectures, I actually talk a bit about, who cares about this? Who cares about simulation? Who cares about, respiratory pharmacology, et cetera? If you can't answer that, okay, if at least you can't kind of scratch your head and say, why am I even listening to this lecture? Then maybe you don't even bother type of deal. This is why. Preceptors perform a critical role in RT education and training, okay, ensuring competency. However, RTs are generally not born with those skills. To do that particular job well, they need foundational, both clinical judgment, critical thinking, and interpersonal skills. They need to basically kind of over time have an understanding that not everybody learns the same way. There's some foundational principles of teaching and learning. And that is, some people are visual learners, okay? There's certain, they talk about men, not reading directions. Well, sometimes men are like that because they tend to be a bit more visual learners, okay? Whereas, and I'm not saying 100% of the time, women, females, they tend to be a bit more, they want to read it type of deal. So there is something to be said to the wife saying, hey, hon, read the directions now that you assembled the bike backwards, the seat's on backwards, the handlebars are on backwards, etc. Now let's read the directions and maybe do it together. So again, there's certain, fundamental principles that that if the preceptor or clinical instructor is empowered with, they can be more effective. They can hit the ground running more readily. They, meaning preceptors, also need to be trained and mentored on how to educate and train others on how to enter our profession as respiratory therapists. Some operational definitions: clinical instructor, generally a paid faculty member who oversees and evaluates. The preceptor is a person who, with expertise in a particular field, in this case, respiratory care, who can, guide, tutor, provide direction to the learner, especially, again, in allied health. Mentor, then there's some, again, parallelism. An experienced individual who teaches or helps a less experienced individual learn more about their chosen role in an organization. Okay, so some hospital systems, at Rutgers, we have a mentorship program where, if you will, I'm a full professor at Rutgers, where I might be matched up with a junior faculty to help meet with them at least monthly and have a kind of an agenda to help, allow them to hit the ground running more readily. Validity. So we'll talk about this today as far as validity of certain tools, certain surveys, certain evaluation instruments that are out there. The extent to which a concept, conclusion, or measurement. So in this case, we're really talking about evaluation scales. Today in clinical, as a clinical instructor, not as a preceptor, I did the final, if you will, evaluation for the 5 students that I actually had for the past about 7 weeks, give or take. And the question is, we use a system called Trajexis. Okay, it's commercially available. It's used by a lot of the educational programs in respiratory care. The question is, they actually changed their scale from a 5-point Likert to a 4-point. And I would kind of scratch my head saying, does that do anything to the validity of the evaluation tool? Can't answer that question, but it's just something that I stumbled on today. Reliability is is basically the ability to do the same procedure in the same way under similar conditions repeatedly. So reliability is kind of like repeatability. Interrater reliability, something I'll circle back on, is the extent to which raters, preceptors, or clinical instructors will evaluate the same students under the same conditions in the same manner. For example, on Thursdays, I do clinical instruction. On Fridays, same group, same hospital, et cetera, et cetera. Another individual, another clinical instructor does the same thing. So the question would be, does the other instructor who does Fridays, same students, same hospital, does she within a certain amount of reasonable variation, do she and I rate the students similarly? Okay. Now there could be some legitimate reasons. She may have had a bad experience with a student that I didn't have. There may be personality clash. There may be issues along those lines. So clearly, you don't expect 100% agreement, between instructors. But if they're all over the map and they're consistently all over the map, it's a concern, and that would be an example of low inter-rater reliability. Relationship among these terms, so mentor, preceptor, clinical instructor. In reality, to be honest with you, the overlap is probably greater than I'm showing you in this, what's called a Venn diagram. Okay. That a mentor and a preceptor probably share maybe closer to, a half of those particular responsibilities and characteristics. Likewise with a clinical instructor. So again, they're not mutually exclusive. There is some parallelism, but they're not the same thing, as I just shared with you those definitions. So trends. So we're saying, well, a little bit of the historical perspective. I'm not going to bog you down, and there's when I say there's an evaluation, of how well we did, but there's no Q&A for this particular live presentation. So this is going back to 2009. 2009. Okay, respiratory care clinical education, a needs assessment for preceptorship training. Okay, so it really looked at preceptorship needs of programs that lead to registered respiratory therapist or certified respiratory therapist credential, CRT, RRT. They looked at, they did a email directors of accredited RT programs. They did it by a survey. There were 74 program directors across state that responded. My understanding is that the response rate was a little on the low side, but it was still that there were still 74. So it wasn't useless data. Okay, it just would have been better if they had a higher response rate. Majority of responding programs use unpaid clinical preceptors. I started to mention this before. The hospital system I work at, the preceptors are paid an extra $3 an hour, okay, when they're precepting new hires and students, okay? Now, they don't do a lot of precepting of students. They do a bit in the summer for their specialty rotations with like the NICU, the PICU, pulmonary function testing. We have a very active bronchoscopy suite where they do robotic bronchs. We don't do the robotic bronchs, but we assist in setting them up and breaking them down, etc. 32% of the respondents indicate that preceptors had received no preceptorship training. So that's only, crucially about a third. Okay, they received none. Like I said, I got a little bit. So I guess my answer to that would be, yeah, I got some, but it was minimal. Among preceptors who did receive training, the duration of training ranged from 1 hour to 6 weeks. Huge variability. I would put mine at the 4 hour thing. Certainly wasn't 6 weeks. It was a little more than an hour. Training was typically delivered by the director of clinical education or the program faculty, an experienced individual, maybe a quasi mentor of that individual. 81% of the response believe that there's a need for a standardized preceptorship training program. So this study, okay, was one of the foundational findings that led to greater standardization of preceptorship training, including the one that's offered by the AARC. The conclusion, standardized preceptorship training is needed. Now, again, this is 2009. This is a whopping, 16 give or take years ago. I do have the citation at the bottom here as well, but it's something to actually think about. According to Newell and Cannon, so we talk a little bit, okay? They are kind of the experts or some of the experts that really talk about teaching in medicine, okay? But not just teaching doctors. And they basically say clinical teaching is the most neglected area of teaching, despite being one where more deficiencies have been found than any other. So really kind of real important, but can be problematic. So it's one of those things that, it's not a good combination. Furthermore, they describe many clinical teaching encounters as haphazard, mediocre, and lacking in intellectual stimulation. So this is secondhand information, but I had found out through the grapevine that another educational program, respiratory educational program, that there was a student who had very little experience, hands-on experience, because the facility where they were was really not letting them. It was a new clinical site. They weren't letting students do very much, and the students suffered. So then this individual went from that site to a site where the students were allowed to do a lot. Okay. And what happened was they were asked the patient had been extubated for 6 8 hours. They were doing really well. They were asked to break down the vent, obviously strip it, wipe it down, and bring it back to the equipment room. Well, instead of using the quick connect, okay, the individual unscrewed it, okay, unscrewed the oxygen attachment, and what happened was it was just hissing. Okay, it was just because it was still quick connect was still plugged in. So it was an embarrassing, and apparently the clinical instructor kind of jumped on the student. How did you not know this? And it's just like it's embarrassing all the way around. But it was like, well, how do you let the student like do that? like you own a chunk of that. That's our job is, and not that it couldn't happen to me or anybody else, but it's something that the reaction of the clinical instructor was to blame the student, and the student was a learner. So you get the idea. So haphazard, mediocre, and I would say that was probably deleterious. It probably was hurtful, not just in terms of the student's ego, but in terms of their learning. When you're unduly harsh on students, their brains tend to shut down. They don't think, they tend to forget stuff that they may actually kind of know in their long-term memories, but they're so, basically feeling like they're under the microscope that they can't, the recall is actually suffering as a result. Trends, a little bit more on the trends. So this is a 2020 piece. So I'm fast forwarding from 2009, 2011, now we're up to 2020. Respiratory therapy administrators' perceptions of effective teaching characteristics of clinical preceptors. Again, not the same as a clinical instructor, but sharing a lot of those, characteristics and responsibilities. The aim was to determine which teaching characteristics are effective. Okay. Total 34 RT administrators participated, representing 18 healthcare institutions. Response rate was, well, it was over 50%, not terrible. Participants showed most interest in professional competence, followed by personal attributes in relationship with the students. So one of the things I'm going to say here is this, is that within a range, if a student is deficient in their knowledge base, okay, and it may be something that's situational. It's nobody's fault. It's the servo I or the servo U, that the only one they had at that particular not a hospital, but college for the respiratory program, it broke. I mean, literally, it broke down. They couldn't use it. So those students may actually have a deficiency with that. Okay, and that kind of is what it is. But in a clinical setting, we have had this happen. And if we know that, we can spend additional time, we can help compensate for that. Okay. Where we have more difficulty, and where many clinical instructors and clinical preceptors do, if it's attitudinal. Okay. So if it's the student, they just don't play nicely with others, we probably have all met the individual who you just know that maybe they weren't hugged enough when they were like, 6 years old, and they didn't play well in the sandbox or whatever. And now they're older, and their social skills are just, lackluster. That's a tougher nut to crack than somebody who, I didn't know this, whatever. I don't know this vent as well as I should. And you could take some extra time, and, you can help close that gap, if you will. And then he really looked at years in clinical practice as a respiratory therapist was negatively associated with participants' final scores. So what they're saying here is the old timers had less empathy. So a certain amount of experience is a sweet spot, but the old timers, it could be problematic. The conclusions, the study indicates that professional competence of clinical preceptors is believed by RT administrators to be the most important behavioral characteristics. Interesting. So we have, 2009, we knew we had a problem. I'm just giving you chunks of time here, but it's probably fairly accurate. 2010 to 15 developed strategies, and we're still developing these, to be honest with you, but it was really the first surge, if you will, to deal with the problem of insufficient training and education of our preceptors and our clinical instructors. 2015 and beyond now, Ohio State, AARC partnered to develop RT student preceptorship program. Okay. 4 online modules. I sound like a salesperson, okay? I'm agnostic when it comes to the AARC. I think they do a lot of really, really good stuff, okay? Honestly, they offer a lot of really valuable tools and resources and clinical practice guidelines. Respiratory Care Journal has a lot of really great research studies that are published through it, et cetera, et cetera. But doesn't mean everything they do is outstandingly good type of deal. I think that what they offer in terms of preceptorship, training program is good. So I don't get anything for saying this about them or saying this about Ohio State, okay? But I will say that I want to make you aware that these resources exist. And I'll talk more about this as I jump into this. So why are RT students preceptorship program valuable? Some RTs and potentially preceptors are more clinically proficient than others. Okay. Some RTs are very good clinicians, but don't have good people skills. Okay. That is what it is. I'm not talking about somebody who's having a bad day. You having a bad day happens to all of us, right? But we're talking about somebody who's consistently having a bad day. Being a good RT is not the same as being a good student preceptor. Okay, so you kind of like that's almost the corollary to the second bullet. Third, teaching and precepting are not innate abilities. They need to be learned. They need to be taught and learned. Highly competent RTs with good interpersonal skills and aptitude still need to learn how to teach and precept students. Again, a little more. Not all RT students' evaluation forms, rubrics are valid. Some of these evaluation forms are not that great. Okay. Validity means, as I said, the ability of a tool to accurately measure what it's supposed to under those same conditions. Factors which can negatively influence validity. An invalid grading rubric. Okay. Interpersonal bias. The preceptor, I don't mean literally, let's say any of you are haters. I'm not a hater. I just think hating is negative energy is just like, well, but there may be a clash. Okay. And so you say, oh, the instrument's valid. So my rating has to be valid. No, it's the context matters. This is really what I'm saying there. Inadequate preceptorship training and education can absolutely affect it. So the preceptors doesn't dislike the student, but just hasn't been taught how to precept and how to use the instruments at their disposal. Poor Interrater reliability. Different preceptors rating the same student under the same conditions differently. And we don't mean slightly differently. We mean vastly differently and consistently doing it that way. So a little bit of evaluation for, again, rubric, validity. Rubric is a form used to evaluate, it's a rating form. Okay. Just if we were just sitting around having a cup of coffee or a beer, it's a rating form. Okay. Academic or work performance. We use them in our courses to, well, how did you determine that Susie Q got a 94 on her final paper? We use a rubric and it's not arbitrary. It's based on various domains and has a scale. It gives examples, et cetera, et cetera. Probably better than many. I'm not saying it is the best rubric, but we use them so that the student can not just see how they earned a 94, but they can also use it as more of a learning tool as well. Just say, oh, I did well here. This is an area I probably can improve in. Similar to when you guys think back when you took the credentialing exams, the TMC, okay, and the clinical simulation exam, okay. For both of those, when you took your exam, the score was given to you. When the score was officially reported to you, it was given to you by category. Okay. I think you have to request that now, but you can see how you did on each category. I took most of my credentialing exams a very long time ago. However, it was about 6 years ago, I took the ACCS exam. And I was keen. I scored, I didn't just get 100. I got like a 90, 92 or something like that. But I wanted to see areas where I passed, but I didn't do as well so that I could actually bone up on those. Okay. And I will tell you, there was some very discrete questions on medications, on vasopressors and things along those lines that I studied hard on, but mechanical ventilation, I really didn't study at all. And I did fine on, but there was a few areas. And again, I'm just giving you one example where it's discrete laboratory results, some discrete medications that we typically don't deal with, et cetera, et cetera. I wanted to go back because I wanted to make sure that I could be the best version of not just an instructor, but a respiratory therapist that I could be in adult acute care. Some don't cover the scope of competencies, covered in that particular semester. So there's this mismatch. I also I'm affiliated with a college, a 4-year college in New Jersey that is launching a bachelor's in respiratory. We just went through a site visit 2 weeks ago, and we did well. They had some recommendations, but overall we did well. One of the things they were critically concerned with, many things they were concerned with, was the relative alignment of, number one, the syllabus. Do the courses themselves cover what they say they're going to cover in a respectable manner? Okay. And then number two, are we actually covering in the semester as a whole, in conglomerate of all the courses that are offered? And is there a logical progression that is planned for from semester to semester? Very, very important. And then they're, concerned about, is there relative unanimity between what's taught in the classroom, what's taught in the lab, and what's taught and what's seen in clinical. And my response to that is always, well, about 90 something percent, but it's not 100%. There's times when students in the first semester have a chance to see a bronchoscopy, and they may not get that chance, for another several months or longer than that. Okay, but they haven't had it yet. Okay, so we'll do a little bit of diversion from just following a sequence like the Stepford Wives, where they get a chance to see something that they're going to learn about eventually. I'll obviously try to cover the context during the break, or like I'll answer questions, I'll describe what a bronch is, et cetera, et cetera. I'll refer them to various sources, including their textbooks, et cetera. But I don't want to deprive them of an opportunity that's an unusual opportunity. Some have flawed, unbalanced rating scales, the rubric, if you will. Others are not sufficiently descriptive and or redundant. So I mean, the categories may be fine, but I'm a little unsure of what they mean by team orientation, okay, and student rather a patient rapport, type of thing. Are they talking when they talk about teamwork? Are they talking about teamwork with fellow students? Are they talk about teamwork with the actual nurse, the practicing nurse, and the RT that's taking care of the patient? What exactly are we talking about here? Some digital platforms are not stable or lack full functionality. So the system that I've used many moons ago was really clunky, archaic, didn't function well, et cetera. So it was down a lot. Quite honestly, the server was down a lot, et cetera. So that's kind of like basic needs. It needs to be functional most or all of the time. An example, okay, what makes this rubric a decent rubric? I'm not saying it's, and it's a piece of paper. So a lot of the stuff is done digitally, including the evaluations I did today. But just to kind of show you an example here. What makes it good? I'm saying not outstanding, but makes it good. It adheres to the keep it simple principle. Okay, not going to bowl you over. It defines the semester and nature of the rotation. It's giving you the student name, delineates between behavior and clinical proficiency. It's really talking about some of these things. Behavioral things, again, are tougher to alter. You can point things out to a student or a new hire as a preceptor. Hey, you kind of like when you make a change to the ventilator, you really need to circle back and let the nurse know that the order came through, but that you're now putting that patient on pressure support and giving them, a spontaneous breathing trial attempt. Score evaluation is simple. It's pass fail. Maybe we could argue maybe that's also a disadvantage because it doesn't give you the opportunity to say, well, discrete measurement, that, the individual could be outstanding. They could be good. They could be sufficient, a 3, a 4, a 5. Sufficient, really good, 4, and 5 is outstanding. And then they could really need some significant work, a 2 or 1 potentially, unacceptable. I don't know if it goes to 0, but you get the general gist. Permits additional narrative comments, which is kind of a nice feature as well. I make a point when I give the evals to the students, I do them in person, meaning I do them, but I'm, just sitting there with them, et cetera, and I'm explaining why I rated them the way that they do, and then they look at me and say, the other instructors just not all, but some of the other instructors they just do it offline, and then I just go in, a week later, and I see how I was rated, et cetera, et cetera. I want them to kind of like see, hear a little bit of the why, and give it, I think evaluation is also an opportunity for them to learn for the next time around. How it can be improved, more discrete ratings, like I just alluded to before. The proficiency should be expanded, and they probably, are not just, as basic as it is. But I wanted to give you, some elements of some of the, pluses and minuses that are out there. This is, by the way, compliments of, I'm giving crediting here, Missouri State University, their consortium that they use. Missouri's really done some nice stuff when it comes to their preceptors. Context matters. Even with a valid rubric, the process can undermine validity. So you're really looking at low emotional IQ of the preceptor, where they just like they're man of the world type of deal, or they don't, uh, give the students a little bit of latitude when, recognizing they have a life, and maybe they're just, some days they're more on it than others type of deal. Poor interpersonal or communication skills, cultural, religious, or other biases, insufficient training and mentoring, and they view the student as slave labor. One of the other things is this. So whether it's a student or somebody who is being precepted, a new grad or somebody who came from, is going from one type of setting, home care, to it's they're not there to do your job for you. They're there so that you can work together with them and kind of bring them up that learning curve more quickly than they would do on their own, and quickly and safely, that they're not, if they're making fewer mistakes, their mistakes are caught before they could potentially harm the patient, et cetera, et cetera. So whether it's, the preceptor or the clinical instructor views a student as slave labor. It's another area where it comes to students. So that's really with a clinical instructor, where the accrediting body COARC is concerned that this does not happen, that they're not just given, here's the assignment, you take these 8, I'll take these 8, and I'll meet you back here in an hour and a half type of deal. No, no, that's not the way that it should be. Yeah, if it's somebody who's very experienced therapist and they're just coming off orientation, then there could be some, let's say, first cousin of that, where you're not leaving them alone necessarily. You're there for them, but maybe you got to divide and conquer a little bit on an especially busy day. Characteristics of preceptors are really kind of like, well, okay, well, that's kind of like, don't do this. Well, this is high level of clinical competence, empathy. So some of this really comes out of that 20 piece that I shared with you earlier. Patience, and that's a hard thing. Sometimes people are, it's situational. You're just more patient at certain times than others. I could go down the rabbit hole. In the interest of time, I'm not going to, but outstanding communication, time management. I push my students. It's like, I want you to be safe. I want you to be effective. But in the, first week of this semester, you may have taken, 2 or 4 of you may have taken an hour to do a vent patient check. Okay. I don't expect you to be as fast as somebody who's been in the field for 10 years, but I also expect that time to come down a little bit, and I expect you to be more thorough and need less prompting. Okay. I give them checklists. I'm there with them, et cetera, et cetera. But I tell them, listen, I'm not trying to be mean, but I'm going to push you, because in 3 to 4 months, you're going to be working. Okay. 5 months, let's say, you're going to be working, you're probably going to have a night shift. There's going to be fewer resources at night. So I'm not trying to be mean. I'm pushing you, but I'm explaining to you the method. It's not madness, the figure of speech. The method to the madness here, okay, is that, and I have confidence that you can be pushed to some extent. Okay. I'm not just going to like babysit you, is that we're going to find that sweet spot between being appropriately precepted, taught, etc., but also that they are the masters of their own destiny and they're taking advantage of that and showing initiative. Appeal to various learning styles. I mentioned before, the visual learners, the learners that actually, sometimes people just, they need to write it out. I swear that you give them something, they want to write something out, and it sticks in their memory banks better. I was never that sort of a person. I took notes, I studied my notes, but I never rewrote my notes. They were like, my notes were so sloppy, I could read them, that they were like hieroglyphics. You needed the Rosetta Stone to interpret that type of deal. That's what the Egyptians used to read hieroglyphics, the Rosetta Stone. Anyhow, also sensitive to things like cultural, religious, ethnic sensitivities, things along those lines. Today we did a one-way extubation, and I did it with 2 of the students. Family was fine. Family was great. And so terminal wean, one-way extubation. And I said to them, listen, I'm not forcing you to do this. So if you feel like this is something that, culturally, religiously, to some other, just you feel it, then not a problem. We could talk about that, not your reluctance, but talk about the procedure. Okay. But no one is ever going to make you do a one-way extubation if it's against you. You can ask for help. I want them to understand that as well. Clinical site. They value, ideally, they value the preceptor's role. And that may be, we only got preceptorship pay, I'm going to guesstimate 18 months ago, something along those lines. Before that, you did it for the better good. Now, again, as I said earlier, I think it's a $3 premium. They track it pretty good. But as a preceptor, you also need to go into the system to get that $3. You need to check them off if they were there doing, let's say, the PICU, that the PICU therapists they're with, that they have specific competencies they need to do. You don't need to check them off on all of them, but it can't be that you had them for 8 or 12 hours and you didn't look at that stuff at all. The actual graduate being precepted owns some of that as well. So they say, go into the site, this is what you have, etc. We used to use binders. Binders were clunky. Now we've just automated it over the past 2 years or so. Clinical sites help provide initial and ongoing preceptorship training and education. It sounds like a bunch of fluff. In a perfect world, some way they facilitate it. They support preceptor pay, and I would say recognition. Pay is certainly one way of recognizing. They understand that precepting takes time and should be accounted for in the workload. If you're going to dump on somebody, okay, and say you have this heavy ass assignment, okay, but hey, you got somebody with you now. It depends. If they're already a graduate or they're ready to graduate, they can be a net gainer. If their first semester, they're gonna slow you down, and I understand, but the workload should be reflective of that. Okay, whether you're precepting, somebody a new hire, or you're precepting students, you're not going to take a full load except for maybe near, as students in a clinical instruction scenario where they are getting ready to graduate and can really kind of like apply a lot of the things that the concepts and hands-on that you've been covering for the past 2 years. Starting or revising clinical preceptorship program, looking at where we are at time here. So model 1, model 2, model 3. Okay, do it yourself. So I'll spend a little time on model 1. I'm not saying it shouldn't ever be done, because sometimes that's it. But if you're doing it yourself, I would say just at least make sure that you're in some way availing yourself, the organization, of some resources that are out there, legitimately so. I'm not talking about stealing somebody else's work, but I'm talking about modeling it, knowing what's out there, reaching out to Shauna Strickland, who really has done a lot. She's published some stuff on this at the AARC, and she's willing to like share stuff and whatever. And as long as it's done for the better good, and it's not like some consulting firm or something along those lines. So do it yourself can work, but as long as do it yourself is not flying by the seat of your pants. Okay. And then emulating. So look at, now we're kind of doing the model 1/2. Now we're going to 2. Emulate another program with permission, a one that's hopefully good. So the first model would be you're taking what elements that you can practically do. 2 is you're emulating it. You're closely emulating the model they use. But again, if you're using the rubric, you let them know and just say, can I please, I'm not starting a consulting business. This rubric is so good. I will credit you on the bottom of it with a footnote or whatever. Is it okay if we use it? Best to get written permission, by the way. A lot of places will not have a problem with it. They will, where they say I don't mean copying, but imitation is a form of flattery. Okay. Again, as long as you're very reasonable and crediting appropriately. Utilize AARC's preceptorship program is another way as well. Model 1, so a little bit, again, advantages and disadvantages. So advantages can adapt the program to the environment. Okay, that should be done in any event. All right, even if you're subscribing to the AARCs, that's still going to have to be adapted. But what we're really talking about is this is like maximum adaptability, quicker to implement. That's probably true. If it's too quick, then it may lack any of the best practices that are out there. So I would say it may be quicker if you're not so hung up on adopting every best practice, but you're going for good with the eventual goal of outstanding. Okay, so you've implemented something, now you have some structure, but you're doing it in increments. Totally legit. Disadvantage is failure to learn from others' experiences and expertise, learning the hard way, so you got to make the mistakes yourself, setting up for a poorly designed and implemented program, poor outcomes, students don't learn, requires the investment of time and resources. So something to think about there as well. Emulating others. Okay. Advantages. Can adapt the program to the environment. Okay, so you can adapt it, same like we said earlier. Collaboratively learn from others' experience, and you don't have to reinvent the wheel. Okay, I kind of like that myself. Disadvantages may be emulating a poorly designed and implemented program. So just kind of look at, what's out there. You have some means of evaluating. It still may involve learning the hard way, still may risk poor outcomes, students who don't learn. Okay. That's a big deal. It was a crappy preceptorship program. So the students that they were made slaves. They were made equipment techs. They spent, a lot of their day taking dirty vents out of rooms from patients that have been extubated, or taking dirty BiPAPs out, or high flows, or whatever or lugging new ones up, whatever the case may be. Yeah, that's part of the job. We have to do that as well, but that shouldn't be most of it. Missouri, again, Southern State University, point to not just the AARC, but also a particular program that, I'm not saying everything should be emulated, but devised RT, a student preceptorship training program, set criteria for being a preceptor. Okay, for being a preceptor. We have some new grads that want to be preceptors, they want to be clinical instructors, and it's just like, so sell me, what are your qualifications? And then I get to smile. Well, I just graduated. That's not bad. The fact that they just graduated, a year ago, 2 years ago, they may lack the experience, but they also still have the empathy. They knew what it was like. Okay. So that's not necessarily enough, but it's not nothing. Rigorous recruitment and screening process. This is at, again, Missouri Southern. Training involves several training modules. They must pass a quiz and ongoing education, evaluation, and training, through a structured curricula, if you will. Sample preceptorship qualifications, Missouri Southern. Again, just going to cut to the 1, 2, 3, 4, 5. Express an interest in working with students at the site. Display enthusiasm. Good. You don't want somebody who's just kind of like, yeah, okay. Demonstrate communication skills necessary to accomplish teaching. Meet with the approval of the program director of clinical, and other, faculty members as determined. Maintain an active state license in, state which they practice. Complete, required preceptorship training to help ensure, I should really say, Interrater reliability. Maintain a minimal rating of satisfactory on employee evaluations, or again, student evaluations if it was that. And all preceptor candidates will review the clinical preceptorship training manual, take the preceptorship quiz, and score greater than a 70% on it. And then again, that the director of clinical, DCE, or clinical faculty member, as far as interrelated reliability, that they're within a reasonable range of variability as far as that goes. These were some of the characteristics. So it's not like if they can walk, talk, breathe, they have a state license, and they have RT after their name. That's a good start, by the way. That's a good start. It's got to be more than that. And again, a little bit. So preceptorship quiz, I'm not going to read it to you. I just, have it. I basically copied and pasted here, crediting them. Okay. But when teaching adults new ideas, it is best to verbally instruct, demonstrate, and then allow the student to demonstrate. Okay. And they're really looking at this as true or false. So this is low-lying fruit. So we're going to say that, well, is it good? Is it not good? Et cetera, et cetera. It's a start, at least. Okay. We could say even more. One of the things that I would say is this, is it wouldn't be terrible to couple something like this, okay, with a knowledge-based questionnaire that talks a little bit about some of the basics of even boutique modes of ventilation, APRV, how, what would be for an adult, give a weight, height, and then to calculate ideal body weight, et cetera. This is a blood gas. Where might you start this patient? At least a range. And then, even start even basic, pressure or volume ventilation, PRVC, just kind of a little bit on the technicals of it. I think it would be safe to assert basic blood gas interpretation would probably be fine. Okay. But then take it a little bit beyond that, a little bit on blood chemistry, et cetera, et cetera. Model three, best to follow the experts, AARC, Ohio State. Again, I don't have any, I really don't think I have any bias towards the AARC. I've locked horns with some higher ups in the AARC. Ohio State, I know a couple of faculty members. I know Ohio State's really leading the charge with the advanced respiratory practitioner, which is going to be like a physician assistant, but for respiratory care. Evidence-based, so the advantages, evidence-based, designed and delivered by experts, don't have to reinvent the wheel, can adapt the program to the environment, and collaboratively learn from others. Disadvantages requires an investment of time and resources. Poor implementation still may not, again, follow the program. So you can have a really good program, but if you're not following it, okay, it's problematic. It's just like, no, I don't want to do it. It doesn't mean you got to follow it 100% because you may need to adapt certain facets of it to match your particular setting. That's fine. But again, it's one of those things, devil's in the details, that where appropriate, that it should really be followed. And again, this is a screenshot, publicly available, just I'm not, whatever, but it's really talking a little bit about, I did put the URL up there, URL, and really talking about the welcome to the AARC clinical PEP course. Okay. It really is to, preceptorship education program. It talks about who, Shauna Strickland on the bottom of that, by the way, is there, she has done a fair amount of information. Crystal Dunleavy, by the way, is still at Ohio State, if I'm not mistaken. So she authored that piece in 2013. Shauna did a piece looking at Interrater reliability, 2014. And then there's a little bit of you can actually calculate an Interrater reliability. We're not going to go down that rabbit hole, so you can totally relax about it. I just want you folks to be aware because this is such a very important task or responsibility. And Lord knows we need RTs, but we don't just need warm bodies. Okay. We need competent individuals. If we have too many folks out there that either are not competent or don't come off like they're competent, our profession is going to lose a foothold. Okay. A lot of what we've worked for, I mean, you could argue a little bit that maybe we've given some of it back. Okay. With just different moves that have been made over the past 5 or 6 years with the workforce shortages, et cetera, that we will lose ground if we do not have a presence at the bedside. And the way we're going to do it is we're going to graduate, high quality graduates, and we're going to help develop them through programs like preceptorship training. A little bit here, guys, screenshot also. So just kind of what you might expect, instructional videos. So they have different modules 1 through 4. There's also this workbook, but to give you an idea that each module has, guess what? Has, videos in it, et cetera, has elements that are baked into it as well. And of course, there's an introductory video just to kind of wet your whistle on what to actually expect. Example of key principle emphasizing Interrater reliability. So reliability, the ability to do the same procedure in the same way. Blah. Interrater reliability, the extent to which preceptors rate, within a reasonable amount of variability. RT student clinical preceptorship training program aims to maximize the validity and Interrater reliability. Here again, Interrater reliability can be enhanced via recruiting preceptors with the right attitude, aptitude, and clinical proficiency, using a valid evaluation rubric and related processes. Related processes is that the preceptors and clinical instructors are trained on how to use it. It's not just, here you go, here's the form or here's the website you go to, whatever the case may be. And proper and ongoing training of preceptors. So it's really monitoring them. Okay, I know this much, that students comment on us. The dean, where I do clinical instruction, she reads them. I don't mind that. You know what? There's going to be occasion when, it's not a flattering comment. I know myself well enough to know that I'm pretty good, but not perfect at what I do, type of deal. Okay. I want the dean and the program director and director of clinical reading these comments because I also know that a lot of the students are really benefiting not just from myself, but from my clinical instructors and preceptor colleagues. They're pretty good at what they do. Okay. Not perfect, but pretty good. I like what I see coming out of the programs, and I like a lot of what I see, not all, but a lot of what I see in preceptorship once these individuals graduate and they start working and they're in a structured orientation program that includes preceptors. Again, a little bit. So the preceptorship program, by the way, it's not free. It's $199 for AARC members, 1 year access. So it's like 4 online modules, 4 online instructional videos, 2 online videos demonstrating student performance for standardized preceptorship evaluation to kind of see how not just the preceptorship at the bedside, but how the actual, evaluation process goes. Okay. And they give you, the ideal student and then the not so ideal student. Downloadable workbooks and handouts for preceptors, downloadable course management documents. So again, I deliberately didn't really want to share a lot of that with you because that's proprietary. The AARC has expended a lot of resources to develop this stuff. But if you can tell, one of my main themes for this presentation is heightening awareness of, number one, how important this is, and number two, some of the resources that are out there. Deliver the training one-on-one in a group setting or both, you basically decide. Further advancement in preceptorships will require individual and organizational efforts. Okay. Individuals in terms of, looking at things like, engaging, that individuals being engaged in our profession, being involved is really what I'm talking about. Attitudes, degrees. So there's kind of like these, individuals can do affirm things, advancing yourselves officially, but also thinking professionally. Okay. And even though a newer grad may be really reticent to speak up and make a suggestion to a doctor, okay? And there are occasionally doctors out there to be like, nah, you're just a respiratory therapist. Most doctors that I encounter, whether they be resident physicians or experienced ones, are fairly open. Not all, but many of them are open. And even though they may not be initially because they don't know you, if you're polite, but if if you know your stuff, eventually many times you will gain the respect of maybe the ones that just really didn't know you. And they were standoffish and, not because they don't like respiratory therapists. They just didn't know, they didn't know you. They didn't have confidence in you. The way we instill confidence in them is by having strong preceptors and clinical instructors who can help develop our workforce so that they can represent, obviously, they can provide outstanding care, but also represent our profession, themselves, their departments, etc., very proudly. Key points coming down the home stretch here. Clinical preceptorship is highly important role. I know I've said that a lot, but you know what? I'm a firm believer, that really important themes really should be repeated. Several models can be used to train and educate preceptors. Some are better than others. Proper preceptorship training and education requires investment, all stakeholders, educational institutions, the clinical sites, the students, etc. The clinical sites want to hire them. You got to invest in. You want to hire them, you got to invest in them. And the advantage of that is particularly if they're pre-graduate, okay, you get a chance to, if you precept them, to say this one's a clunker. They have poor attitude. So you don't have to hire them, type of deal. But you also get a chance to mold the newer grad or the new grad to your own liking, to the organization's corporate culture, okay, of, let's say, a quality culture and a culture of teamwork where nobody goes to break on a particular shift until everybody is caught up. Or, for the most part, I'm saying that there's this esprit de corps. It's not like, well, I'm going to go to break. I don't care how Susie Q is getting killed in the unit. Whatever, doesn't matter, type of deal. Some of that is corporate culture. Some of that is leadership. And that's a theme of these, or many of our presentations. We're talking about leadership. It really is a leadership issue. It starts there and it works its way down. Stakeholders, again, students, the clinical sites, educational institutions. That investment often pays off. Using expert resources such as the AARC program can also pay off. Keep abreast of new developments. Again, 2009 didn't exist. 2012 didn't exist. These resources exist now, and I'm sure there'll be others. These will be refined further, and there'll be others down the road as new research is evolving and as the preceptorship programs on which they base are as well. Some particular resources that are here. I want to thank you guys very much for joining this presentation, and hopefully you got something out of it, and hopefully you're going to be coming back to A&T for your CEU needs. Thank you very much. Have a great day.